Great. Well, thank you so much, everybody, for joining us this evening. We will just give you a couple of minutes to all get in and get comfortable. My name is Liz Barton, and I am the Head of Communications at VET.CT, and I'm delighted to be hosting this webinar this evening. Before we get going, just to tell you a little bit about VET.CT, we're a global company of over 200 specialists, and we're all here to help you, whether you're in first opinion practice, universities, emergency or specialty hospitals, or any other clinical setting pretty much. We've been providing a world-leading radiology service for over 15 years, where our board-certified radiologists provide expert interpretations on a range of imaging modalities, including X-ray, CT, MRI, fluoroscopy, and nuclear medicine across the full range of species. And what really sets us apart as a radiology provider is the quality of our reports. So we take great care to annotate the images so that you see the areas of concern that our team are looking at. And we ensure the reports you receive contain clinically relevant differentials and comments. All of our reports are backed by our unique clinical warranty so that you can trust the information in them and proceed with the next steps for your patient with confidence. Not only this, but we have an incredible support team who are all clinically trained and are available around the clock every day of the year. And you can ask them for help and support at any time. You also have the ability to communicate directly with our team of radiologists if you have any questions about your case or your report. And in addition, we have a team of specialists from across many different specialties who can provide clinical support and advice on your case beyond radiology. So if you'd like to learn more about the difference VET.CT can make for you and your team and your patients, please do scan the QR code on screen to view a few of our example radiology reports. You can also reach out to us at the email address sales@vetct.com to find out more, ask any questions, and arrange a no obligation discovery call at a time that's convenient for you. So just a little bit of housekeeping about the webinar tonight. It is being recorded and we will share the link with you in the coming days so you can replay any part of the webinar, and please do share it with your colleagues if you think they would enjoy it as well. The talk will be about half an hour long, and then we will go into a Q&A session, and we'd love to receive any questions that you may have as they come up during the talk or at the end. So please do use the Q&A box at the bottom of your screen. I will then collate them and field them to Ralph on your behalf because we don't actually have microphone capacity on this webinar. So, to introduce you to Ralph, I'm delighted to introduce Dr. Ralph Lloyd-Edwards, who is a radiologist and resident educational support senior lead at VET.CT, and he just completed his PhD. He's an exceptional radiologist and fantastic teacher, hence his role supporting our resident training services alongside reporting your diagnostic images. And this webinar is about the use of CT in cats and dogs, which is growing rapidly, and our team get asked for a lot of help in improving image quality in order to improve diagnostic accuracy. And Ralph's talk is part of a series, and his discussion tonight is on clinical cases where you might want to consider CT. So welcome to Ralph, and over to you.
Lovely. Thanks very much, Liz. Really appreciate it. Perfect. So thanks very much for joining us tonight. It's really, really appreciated. And hopefully we can have a nice kind of, I'll try and keep it as close to time as we possibly can. Quick discussion on following on kind of why you might want to think about CT. We're going to go through and try and apply the concepts covered in the technical lectures. So a little bit of ground is going to be recovered, but predominantly this is going to be trying to take those concepts and then really apply them to clinical cases to try and illustrate the key advantages of CT and when it might be appropriate for your patient. Throughout this, I'm going to try and address these 4 key questions. So kind of why you might want to choose CT. And that's the main topic of today, really. I'm just going to focus on cases. We're not moving beyond the head today, but just trying to focus on what are those key advantages. Why would you want CT for your patient? What information CT could provide. So this is where we're going to move on to next week, where we're going to go through what sets CT apart and how it compares to other imaging modalities, when CT might be indicated, and I'm going to try and keep on linking things back to how CT could influence your patient outcomes. So the idea of this isn't just a diagnostic imaging modality should never be a theoretical exercise. It should be a carefully thought out and applied test, which really does influence your patients and allow you the kind of optimal management moving forward. How are we going to be structured? We're going to go through 4 sessions, the first 2 presented by myself and the last 2 by Olga. In each session, we're going to review 3 cases over about 30 minutes with the following QA. And the cases we've chosen quite carefully to illustrate a particular strength indication because they've got nice comparative images. There's a kind of reason behind all of them. We've just not picked kind of random cases. This does mean we've tried to focus on particular teaching points and we've tried to make it as concise and applicable as possible. So there may be small aspects which we don't mention. There may be things which, an aspect of a case which might not be quite as applicable to all of those questions, but it might be just chosen to illustrate kind of one particular point. Interaction welcomed and encouraged. As we've said, there's going to be a QA at the end, so please do just put in your questions and I'll try and address them as well as I can. Key learning objectives. So we're going to try and go through the key strengths and why it is a fantastic imaging modality, kind of in the right setting. To differentiate how it varies from other imaging modalities and when that could mean it's indicated over others, and also how it can change patient outcomes and help your patients. So without further ado, we're going to move on to case 1. So case 1 is a 2-month-old female entire Cavalier King Charles Spaniel. There's a history of anorexia and acute pain associated with opening the head and the jaw. So on every one of these cases, I'll just pause this for a second. I'm going to try and take you through exactly the same views. We're just going to stick to the head and just to try and give you kind of consistency between the cases and enable you guys to do a bit of reading as well and to start to pick out the findings we're looking at. These 2 views, this is a transverse view with the right side of the patient on the left side of the image, and this is a sagittal view. So if you think about a standard lateral radiograph of the head, this is the equivalent kind of orientation. It's just a very thin section straight through the middle. What I've done here is I've kind of reconstructed the images, partly to make sure everything's perfectly straight, to kind of give us the best chance of interpreting as possible, and partly so you can have this guideline. So as we move from the transverse image, that's going to correlate with this purple line to try and kind of help with orientation. So if we're going on through here, already this you can just see the fantastic amount of detail on offer. I'm just going to let it play for the moment, but if you think about the fact that a single radiograph gives you a 2D image of a 3D structure, it gives you an impression. It gives you, a kind of you shoot radiographs on one side, you collect them on the other, and you see what got through into that one 2D image. You can just see the contrast to CT here, where not only have you got the single image, you've got just this huge data set of collection working through the skull and giving you, instead of this kind of impression or this projection of what's present, you can look at very objective data throughout your patient. You have, exact attenuation values for exactly this portion of the tooth, this portion of the cortex, the tongue, moving through the nasal concave here. You just have so much information at your fingertips moving through your patient. This is a bone algorithm. So if thinking back to kind of Manuel's talks, the point is here, this is a very, very wide algorithm. Downside of that is if you look at the brain and the soft tissues, they're all just kind of dark gray. You don't get a huge amount of information. The upside of that is you get a huge range of information across different densities. So on here, you can see tiny little delicate nasal concave. You can also see really thick dentine. You can get soft tissue. You just get an impression of the entire thing. So on looking through here, just to kind of keep your orientation, these are the teeth coming through the nasal cavities. This is nasal septum coming into the maxillary recesses, tongue over to one side here. And then here, if I pause it, just for comparison to some later series I'm going to show you, these are the eyes. So you can see this globe coming in here, and here. And again, just because this is a bone series, we don't get too much information throughout these soft tissues. But what we do get is this brilliant information about the nasal conchae and all of the osseous structure. Oh, don't know why that skipped forward. That's frustrating. Here you go. So what we're looking at here, then to come back to where we were, eyes, brain, coming through the nasopharynx, coming through the mandibles, zygomatic arch, temporomandibular joints, ears. Ears are a fantastic location for CT because they're so deep and you've got such a variety of tissues to kind of assess. And then finally coming towards the caudal aspect of the head and neck. So, take it you've all got the answer, right? But the downside of all of this information is you're blasted with it. There is a huge amount of detail here, so it's trying to pick through what you've got, and this is where kind of interpretation comes in, and where this can be really, really challenging. You've got this huge data set, and now you're trying to make sense of it. You're trying to do something with it and get something meaningful, which kind of really helps your patient. And to be perfectly honest, when I scanned through this for the patient for the first few times, I didn't see anything at all. I just went straight on through. So what's helpful in this case is we've got detailed assessment of every osseous structure. You've got this total lack of superimposition. So if you think about your skull radiographs, normally when you've got kind of one temporomandibular joint projected over the others, you've got an impression of the nasal cavities. Here you can pick out each individual voxel and just give it an objective value as to exactly what's there. Downside is it's challenging to spot the problem. This can be quite tricky. What's an advantage of CT, and one we'll come back to over and over again, at least traditional CT, is you can go beyond the bony structures. So that previous series was a bone algorithm. This is looking through exactly the same data, which has been collected in the same scan, but presented as a soft tissue algorithm. The difference here, if I skip to about halfway through, is rather than having a big range of interpretation, you've got a very, very narrow range. This is really focused around soft tissue and fluid. So you can see the difference between, if you think back to what the eyes looked like in the previous scan, just dark grey, really. You had no detail. Here, you've got this lovely, lovely image of the lens, vitreous, brain, and you can see all of these different differences in the soft tissue. You can see the third ventricle coming on through here. So not only have you got this kind of lovely detailed osseous anatomy, you can also get a fantastic tomographic impression of the soft tissues coming through. And you can use natural changes in density, things like fat sitting with the tongue, the difference of the vitreous. You can see here retrobulbar fat. So the differences in density to let you pick apart the soft tissues. And this also can really aid interpretation, not only of the soft tissue structures, but kind of guiding our interpretation of the bony structures. So if I replay this and on this way through, just try and look for symmetry. So in imaging, we're kind of given a gift, right? Where normally if you're looking for, or at least if you're looking for a unilateral pathology, you've got the other side to look at. It's just, it's kind of spot the difference. So on going through here, we're going to look for any changes which we can see from one side or the other. So if I pause it just here, and you can see this side, that's a nice normal masseter muscle. And on this side, you've got this huge, great big increase in volume. You can see this big bulge and this area of fluid surrounding, or reduced attenuation surrounding the mandible. So in using the fact that CT gives you this soft tissue information in addition to bony information, we've kind of identified already, rather than looking for subtle little changes, we've got this kind of big abnormality here, which we can then use to kind of guide our further examination. So if I take us on to the next slide, and hopefully this works. This is the kind of region. I'm going to use this view a few times, so I'm just going to explain it now. This is transverse. So this is basically a cut straight through the patient, as we've been looking at. Sagittal or parasagittal plane. So this is again looking with the rostral aspect over here, caudal aspect over here, dorsal and ventral, and then this is a dorsal plane image. So this is cutting through as if you're taking a dorsal ventral radiograph. So I've reconstructed it on these few different views. So CT allows this, you've got this data set, and not only can you look through it in slices, you can play with it however you like. So here I've cut it into multiple planes, so you can really define the extent of this swelling. So thinking about the presentation, acute pain, acute onset, we could be thinking about things like abscess, hemorrhage. There are plenty of options here. And we've already got a kind of very significant finding from the study. But then if we go back and use that information that we gained from the soft tissue series and start applying it to bony. So now we know what area of focus. We know just to keep our eyes peeled on this left mandible here. And just keep your eyes peeled on this the whole way through. And I'll just play that one more time. Just here. And this one, you've got this nice, or not nice, but this sharp, well-defined fracture straight through the medial aspect of the articular surface of the mandible. And so by using this kind of combination of factors, this huge kind of sensitive and very detailed examination that CT gives you in combination with the overview to give you a good analysis of the kind of soft tissues as a whole, that can really bring fantastic results and a really nice sensitive examination of the patient. So I don't think we need to watch this again. So I'll go straight on through. So this is exactly the same thing. So it reconstructed in multiple views. And you can see here, this fracture line in dorsal plane, little chip. And then also the fact that this is a normal width of the temporomandibular joint and this side's displaced. So not only is there fracture, there's also an instability of the remaining joint. Okay, so summary of the findings. We've got this closed, complete, acute displaced articular fracture. We've also got the soft tissue swelling, so most likely kind of hemorrhage and contusion surrounding it. And as is often the case with CT, you don't only see what you want to see, what you've kind of put the animal in the CT for, you also quite often get additional findings. It's such a sensitive modality, you can pick up other things. So in this case, you can see the cerebellum kind of nice or crowding the foramen magnum. So unlikely to be of any kind of current significance to the current problem, but it's there, so it's described. So what does CT tell us? It gave us a potentially significant finding for the clinical signs themselves. It also gave us a time frame. The fact that there are these soft tissue changes, this means this is very unlikely to be an older fracture, and the fact that the margins are so nicely defined. So how does it impact our patient? We've got a diagnosis. We've got detected this tiny, tiny little fracture, an instability of the TMJ, and we've also highlighted additional findings which might be significant in the future. I suppose the question mark here is, could this have been achieved in a different way? The short answer is yes. This may have been detected on radiographs, but it's challenging. These are a huge caveat involved. We didn't have radiographs of this patient, so I made these from the CT. They are not of comparable quality to the real radiographs. So just take these with a pinch of salt. I've tried to put the note to make it very, very clear and not misleading. But you can just I've included them to give a bit of an impression and just a reminder of the amount of superimposed structures we're dealing with on a radiograph compared to this kind of pinpoint tomographic accuracy which CT can enable. So yeah, radiography could have worked, but it would have been technically challenging. Ultrasonography, you might have detected those soft tissue changes, but probably not the fracture. And MRI, great for brain, but sometimes a little bit less sensitive for fractures, just due to that spatial kind of resolution. Key points. So CT allows this really sensitive detection of osseous abnormalities. I chose this case because it's a tiny little finding. It's a really challenging one to spot. But by using the fact that CT can look at soft tissues, it can have this really high sensitivity bony information, and also that it's tomographic. You can separate all of these interfering structures and get just to the bit of interest. And I thought I'd put this on the end. We're an interpretation company, but skill interpretation is key. CT is a challenging modality sometimes, and having a little bit of experience in looking at them can be very, very helpful. Put in a couple of papers just for your interest, as much as anything else. But to try and make sure we kind of stick as close to time as possible, I'll move straight on to the second case. So in this case, it's a female domestic short-haired cat. It was a stray in this case, and it's had a road traffic accident and was brought in by a kind of good Samaritan. These are the images. They're in exactly the same orientation as the previous examination. So this is kind of slices looking through the patient, which are represented by where this purple line gets from. And already, this is a very, very different case to the last one. If you just start to focus your eyes in and remember kind of what these, last time these were aerated nasal cavities, just full of gas and delicate little conchae, and you can just see they're filled with this kind of soft tissue and fluid material. If we're stopping it here, last time we were looking through for one very small fracture. Here I can count, 1, 2, 3, 4, 5, 6, 7, 8 on a single slice. So this is a case where there are really quite, I don't know why I restarted, really quite dramatic findings the whole way through. And you can see this is a bony algorithm, but you can still see the soft tissues, the fact that they're disruptive, there's gas bubbles throughout, you've got more fracture lines coming on here. So unlike the other one, when you're looking for that kind of really high sensitivity to try and detect the one finding of interest, I think one of the benefits of CT in this case is the fact that you're picking up a number of them. You haven't got interference from one to the other, and you can just look through. You can use the fact that it's a tomographic modality, and you can pick out each individual change and really list them. You can have this huge amount of findings, and they don't kind of interfere or summate with each other. So you have just as good a visibility on kind of 20 fracture lines in this, or however many there were, as you do with the one. So that can be really, really helpful. The other helpful thing in these kind of cases is, so that's kind of looking at the micro, detecting the individual fractures and being able to assess each one individually. What's also really, really useful is the fact that as well as reconstructing data in multiple planes, you can get this overview. So this is a 3D reconstruction of the patient. These can be really, really useful for getting a good overview of what the patient, what the kind of collection of findings gives you. You can go through and transfer slices and you can see all of this, these tiny individual findings. But this gives you kind of a macro idea. It allows you to see the fact that, oh, you know what, that nose is kind of already kinked and off center. You can see the fracture line coming down here. You can judge things like the alignment of bone. You can start to look at, instead of just almost getting lost individual findings, you can give a really good representation of exactly what you're dealing with, which can be really, really helpful. Okay, so moving on through. So just to come back a little bit and to give an idea about the amount of findings in this case and how they can be so nicely simplified in that 3D reconstruction, I just tried to highlight some of the fractures with blue arrows here, and you can just see the amount of them as we're kind of going through this patient, and just how well CT does on kind of detecting and allowing detection, allowing assessment of exactly what's going on. So for summary, at this point is you have multiple acute, open and displaced skull fractures. The question is kind of, what next? Well, the point is, in addition to allowing, detection of all of these findings, it can be really, really useful to kind of zone in on what are the really key clinically applicable points. What are the kind of major findings which are going to impact the welfare and the outcome in this patient? And in this case, I've tried to zone in on a few key findings. So the fact you've got pneumocephalus, you've got gas within the kind of meninges surrounding the brain itself. You've got articular fractures in addition to fractures of the face. You've got this fracture and aperture going into the kind of from the oral cavity to the nasal cavity. This destruction of the medial aspect of the retrobulbar space. So all of these are, are not very positive things, and but they do allow, detecting them now and getting a good idea of what is going on with this patient, of exactly what is affected immediately, allows that appropriate management as it's needed. So what did CT tell us? It detected a huge amount of fractures. It allowed classification of a large number of fractures. So not only did it say it's there, we know the age from the, or the rough age from the appearance. We know exactly where they are, what they affect. We can give an overview of the alignment. So not only are we doing this, as I showed you on the slides with all of these fractures kind of highlighted, you're not almost doing a collection of findings, you're seeing what the kind of overall effect is, and how that impacts your patient. You've got soft tissue assessment. I only highlighted the bony algorithms in this case, but you can have a fair assessment of the soft tissues on the way through, and you can have a really targeted assessment. Here you're really interested in what is going to be affect the outcome for this patient and what key anatomical structures are identified. And finally, the fact, again, it's tomographic, and this is really important in the head, where I think you all probably can appreciate the difficulties of radiography of the skull and of the head, but just the fact that you've got this tomographic imaging modality to kind of pick out all of the individual findings is really, really helpful. So in this case, the diagnosis was relatively straightforward. They had a very good idea it had fractures before putting it on. But I think what's important here is the additional information about prognosis, informed decision making, and kind of management points. Could the outcome have been achieved in a different way? Ultrasound could have given him soft tissue information. You can sometimes also detect, step formation, but it can be quite challenging. Radiography would have or could have identified some fractures, but I think where CT possibly would have given the extra advantages in this case of those key findings. So not just knowing those fractures, but knowing exactly where they are and which important structures are affected. MRI could have given additional information, particularly about the cranium. So MRI is basically, it's sometimes, or in a lot of sequences, doesn't give the same spatial resolution, but it does give this very, very high contrast resolution about the soft tissues involved. So that makes it excellent about assessing the CNS particularly. So it would have given additional information, but it also requires a much longer anesthesia. It's quite often more limited in its availability and also the expense involved. So MRI is something which could be considered, but possibly not in, possibly CT gave a faster kind of route to your key questions at this point. So the key points from this case, CT gives an excellent ability to collate and assess multiple findings. That lack of interference allows you to kind of go from, there's skull fractures to really what are the key findings and kind of listing them out. It doesn't just enable a diagnosis. So in that first case, we really wanted the diagnosis. We wanted to know what's wrong. In this case, it's more a case of prognosis management. What additional information can we get? Perfect. So without further ado, I'll go straight on to the third case. So this is a 7-year-old female entire Labrador Retriever. It's a history of being unable to open the mouth, and there's a swelling in the dorsal throat found at intubation. So I'm going to go through the images and video first. So again, exactly the same orientation, exactly the same setup, and going through the brain. Actually, I'll start it again. Teeth, eyes, cribriform plate and brain, frontal sinuses. Then this is the mandible, hyoid apparatus, coming back to the ears, external ear canals, and finally going onto the neck. So if you have a good look at about this kind of level, and again, imaging with just looking to spot the difference, and you can see already there's this kind of chunk missing from the mandible on this right hand side. If I go a little bit further back, then it's restarting. Then you see just how extensive it goes. So you've not only got a chunk missing, you've got this quite aggressive kind of pattern of osteolysis widely affecting the mandible, and also jumping across and affecting this part of the temporal bone as well. So already from this bony series, and actually I should have mentioned that as well, and as well as affecting those regions, if you look at the contrast between this is the right middle ear, this is the left. So this one's really kind of filled in with material, and this one is gaseous as you would expect. So already from this bony series, you've got an aggressive polyostotic lesion. But if we go on to the next series, so that's already a lot of information to guide, what you might be dealing with here. But coming back to remembering from that first case, CT also gives you the soft tissue information. So not only do you know the fact that it's got a polyostotic aggressive osseous lesion, you can also start to have a look at the fact that there's this big soft tissue lesion surrounding the affected mandible and extending into the the muscles of mastication kind of surrounding it, you can start to pick out the margins and the exact infiltration of a kind of soft tissue component of the lesion, as well as the bony. And we haven't seen, I don't think I haven't included any cases with this yet, but another major advantage of CT is, in addition to relying on an inherent contrast of soft tissues to give you this information where you can already pick out the lesion, but it's, it's a little bit difficult to marginate in places. It might be a little bit unclear where it stops or starts. We can also give intravenous contrast. So the intravenous contrast medium flows through and kind of highlights or causes increased attenuation of vascularized tissues. So what you can get from that is more information. So this is a scan with contrast medium used. You can see here, these are the kind of various vessels within the tongue. Facial vein over this side. See the enhancement of the kind of eye. These are the zygomatic salivary glands just here coming on through, and again that beautiful enhancement, just letting you see where they are. But if you go to the level of the lesion, suddenly you've got this huge amount of extra information. You're not trying to work hard to delineate, to see the lesion. You can just see the difference of this is a process which has caused this kind of decreased central, increased peripheral blood flow. So you've got this really detailed delineation of the soft tissue component, as well as the detailed osseous kind of information about the bony structures. So it's a really key strength of CT, the ability to use that contrast medium. Here's a little bit of a comparison. So just these are taken at exactly the same level, but just to get an idea of the extra information that can be achieved with contrast medium. So it's looking at the lesion itself. It's also looking at the surrounding structures. If you're thinking about surgery or management of some time, you don't only want to know kind of the lesions here, you want to know what's next to it. Where are your large vessels? What are you trying to avoid? Where's your best angle of approach? And this can be really helpful in that regard. This is a multiplanar reconstruction. So again, we're not limited to those single transverse slices. We can look at it in multiple planes to really get a good idea of where it extends, what it's pushing out the way. You can see the impact on the airway here. So this is what they saw at intubation. This should be a nice, straightforward kind of tube of almost gas within the oral cavity, and it's just being indented by this kind of huge structure. And going back similarly to the last case, not only is the fact it's there, not only is it the fact it's this big, it's what does it affect? And this yellow arrow is really key. So this is one of the foramina going into the skull, and you can see the mass extends the whole way up to it. And there's kind of equivocally or possibly some increased enhancement next to it. So we know at least it extends to the level of the foramina, but we know that, that really important, that really key proximity to the central, to the brain itself. So summary of the key CT findings, we've got an aggressive polyostotic osteolytic soft tissue mass with strong peripheral and little central contrast enhancement, and it's centered around that right temporomandibular joint. The key thing with CT here is we've got the osseous information, we've also got the soft tissue, and that enables you to really see here, you can see this chunk of the mandible missing on the 3D reconstruction really nicely. And here I've tried to roughly estimate the margins of the lesion. And so you've got this kind of superimposition, this key complementary aspect that you can assess both parts of this lesion. So what did the CT tell us? Well, in this case, it told us the kind of likely diagnosis. We are looking in likelihood at a neoplastic lesion. We are looking at, we can classify exactly where it extends. So in this case, we can actually even look at the likely type of neoplasm. The characteristics are very suggestive. We can look at the osseous changes associated with the lesion, the soft tissue macro extension, and also the localized lymphadenopathy. So not only with the CTA limited to, there's a lesion in the head, let's look at the head. It will also give you an idea of at least enlargement or changes of the localized lymph nodes. You can also, of course, take the chest to look for metastasis as well, or the abdomen if appropriate. But it allows you a lot more information beyond the kind of lesion itself. So how did CT impact this patient? It allowed informed decision making. We know the likely diagnosis. We have the characteristics of a lesion. We have the extension, the fact it's getting back close to the brain. We can look at secondary findings such as lymphadenopathy. We can even take the thorax, if the patient's on the table already and there's an indication to do so. Could it have been achieved in a different way? Yeah, so radiography would have given you the osseous features. Skull radiography is challenging, but this is a fairly prominent lesion, so I think it could have given you quite a bit of information. Whether or not it would have picked up the involvement of the temporal bone as well as the zygomatic and the extension of those osseous changes, it would have been more challenging. Ultrasound, it would have picked up the soft tissue changes, definitely, but you would have been lacking that osseous information. And also, if you think about the position of this lesion, you've got mandible over the lateral aspect, you've got airways over the medial aspect. So you're quite limited in some places as to your angle of approach. So some aspects you could really probably assess quite well with ultrasound, but perhaps not all of it. MRI could have also led you to this same outcome, but again, it's that question of availability, expense, and which is more appropriate. Okay, so the key points and the reason why I kind of included this case is to really demonstrate the advantage of the TCT as a tomographic modality. It's the fact that you can cut through every point of the patient. You can delineate the margins, or at least the macroscopic margins of a lesion. You can look at the bony structures, and you can just eliminate all of that complex superimposition and also anything getting in the way of modalities like ultrasound. So it's really a strong, a modality in these kind of cases. Intravenous contrast, I think it really, it lights up the lesion is very, very well highlighted, and also the structures you might be concerned about if you were thinking about, even biopsying it. What are you going to avoid, and where is your kind of safe window? Key point here: CT is not histopathology. This lesion has, features suggestive of kind of mixed with sarcoma would be a very higher differential, but it's not histopathology. In some cases, particularly in some organs, we will just describe a structure and we will give differentials of what is possible, but it's not always possible to say, what something is. You can say it's there, but working out what is quite challenging. And finally, CT can give additional information to guide prognosis and management beyond the diagnosis. So final roundup, apologies, it's gone a little bit late. Take-home points. So CT allows, like the first case, accurate detection of subtle osseous changes. You can characterize, localize, and kind of illustrate a large degree of complex or mixed changes. You can differentiate soft tissues, and it's this combination of kind of a soft tissue and osseous enamel information, which can be really, really useful. You can remove superimposition, but it does require critical critical analysis of the input. I'm not suggesting CT is perfect for every patient, far from it. Every modality should have a carefully thought out rationale for why it might be correct, or why it might be considered, and why it might not. And that's where kind of expert interpretation, also guidance on which patients may be suitable and which patients aren't, can be really, really helpful. Perfect. Thank you very, very much for your attention. It's really appreciated. And I think we're going into the questions, if that's okay.
Yeah, thank you so much, Ralph. Do drop any questions that you might have in the chat box. I mean, just as you were talking through those cases, and thank you so much for those, they're a great illustration. If the for example, the patient was stable enough, like that feline patient with the head trauma, and if other sort of contextual care factors allowed you to choose between MRI or CT, would you have a sort of preference for trauma cases of one over the other?
I think CT is often a really nice choice. I think quite often it comes down to practicality of what's available, and also anesthesia. For an MRI, a patient has to be still for a long period of time. It can give unparalleled information about the brain, particularly. So if you're looking for a really high sensitivity examination of the brain, MRI is perfect. But CT can already give you quite a lot of information. It can give a detection of it can be really good for osseous structures as well, which MRI can do, but CT just particularly shines at, just because of that large inherent difference in density. And also CT can give a certain amount of information about the brain. So things like large hemorrhages, mass effects can often be detected. So I think CT can often be a really, really good choice.
Yeah, great. Thanks. And you were sort of showing the power of contrast there. Do you always recommend using the power of contrast in CT, or is that, again, sort of dependent on patient factors?
I think dependent on patient factors is fair. I'm going to try and avoid saying too much because I can't remember what our exact guidelines are, which we give to all clients. So I'm going to try and not contradict anything there. But in a lot of patients, it can be really, really helpful. I think the key thing with CT is you can achieve an awful lot retrospectively. So once you've got the patient there and you've kind of acquired the images, if we want, we can reconstruct it in different planes. We can do 3D. You can even reconstruct it in different algorithms and then send it through again. But we can't add contrast retrospectively. So I think that's the difficulty, particularly in looking at things like the abdomen. If we're looking at a CT and there's a maybe possibly enlarged region of the spleen, let's say, it can be really frustrating not to have that in retrospect. So in most cases, I think we recommend contrast. Sometimes orthopedics can be a little bit different, but yeah, I'll try and avoid giving definite guidance in case I contradict anything else.
Now, I guess the other key there is that we have some guidance that clients can use to
Yeah,
sort of
exactly.
inform use of contrast, which have been very carefully thought through by a whole team of experts. So thank you for that. And just sort of thinking about the ocular structures there. I mean, do you think CT is useful for ocular structures, or would you go for something more like ultrasound first, for example?
Yeah, really good question. So I think CT is fantastic of giving you an overview of the region and particularly the retrobulbar structures. It's great. So if you've got a lesion which, like we showed the trauma case and the fractures of the medial aspect of the orbit, CT is really, really useful. If you've got an exophthalmos and you're trying to find the source of it and you can't get to it with ultrasound, CT's great. If fine structures of the eye, detailed soft tissue information, structures like the kind of anything kind of within the globe, I think ultrasound would probably be my first port of call, at least as a first attempt. But then CT is always an option if needed.
Yeah, great. And obviously we saw some quite marked changes within the middle ears and the ear canals. Is CT sort of your recommended go-to for changes within the middle ear?
Yeah, definitely. CT can work really, really nicely for the middle ear. I think I do come back to that aspect of that CT isn't histopathology. So we're quite often able to say, there's material there or there's not. We might not always, things like differentiating an early inflammatory from a non-inflammatory infusion or something can be quite challenging, but I think it gives you really good structural information about what's present. It can detect secondary changes, so things like if there's osteolysis, if there's possible extension, it can be very, very good. I suppose the only cases I'd possibly hesitate on is if you've got a very strong suspicion of CNS involvement. So if brain involvement is your kind of primary question, then of course MRI can really shine in those cases.
Yeah, that's great. We've just had another question drop in. So thank you for everybody for staying with us. So this question says we had a rare case of nutritional hyperparathyroidism with signs of progressive jaw movement limitations and later restricted head movement. They did CT and MRI for neuro, but on physical examination, rubbery jaw, with radiographs and lab findings, they diagnosed this. Sorry for the long question. Is it possible to miss these findings?
Right, CT. Uh, I suppose you're referring then to maybe CT or MRI. Yes, in short. If you've got a diffuse and symmetrical process, such as seen with, diffuse osteopenia, it can be really, really, really challenging, particularly in early or subtle cases. Yeah, at radiography or CT, it can be very challenging to detect. I think CT is an objective modality, so you can do things like compare Hounsfield units, but I would be very surprised if every radiologist did that as a kind of first port of call. So yeah, but those kind of diffusely affected cases can be challenging. And I think also in those kind of cases, if you have a possible answer or a very strong indication from your clinical findings, from your radiographs, CT can give you a massive amount of information, but you have to be very, very clear on what you're hoping to change in regards to the patient outcome and what's going to be, how your course of management is going to alter based on that.
Yeah, I guess that just shows the extreme importance of clinical examination and lab findings when it comes
Yeah,
to the utility of diagnostic imaging and the overall diagnostic process, doesn't it?
definitely.
Great. Could you just forward on to the next slide, please, Ralph? So that's we've reached the end of our webinar. No further questions. So a huge thank you to Ralph. And just to say, we have some more radiology webinars coming up over the next few weeks, as we've mentioned. Some are more about the sort of concepts of CT, and some are more case-based examples ongoing. And you can always watch back the ones that were more about the CT concepts as well. So yeah, if you'd like to know more or view any of the webinars, then please do click the QR code. And once again, just to remind you, if you'd like to learn more about VET.CT and how our services can help, simply reach out to us. We've got a lovely, friendly team who can answer all of your queries there. So thank you again to Ralph. Thank you everyone who joined us. We hope you enjoyed it and found it useful. Hope to see you next time. Thank you.
Perfect. Thanks very much.